Hello, and welcome to episode 10 of the Safe4F Stories podcast. I'm Jill Ramsay-Stewart, Network Leader with the Integrated Access and Flow Network and Safe4F Provincial Lead. Today, I'm chatting with Angela Oldford, Health Services Manager with Nova Scotia Health at the Halifax Infirmary, QEII Health Sciences Centre. To give you a little bit of background on Angela, she obtained her nursing degree from St. Francis Xavier University in 2001. Angela began her career at Foothills Hospital in Calgary. In 2002, she returned to Nova Scotia to work in orthopedics. In 2004, she took the critical care nursing program and joined the coronary care unit at the Halifax Infirmary. With over 21 years experience, Angela has worked across CCU, Intermediate Care Unit, and the Cardiac Catheterization Lab. In 2023, she stepped into the role of Health Services Manager for 6.2 Cardiology. Welcome, Angela, and thank you for joining me on the Safe4F Stories podcast.
Thank you. Thank you for having me.
So I understand you recently attended the Central Zone Quality Summit. So how was your experience at the summit?
It was a great experience. It really highlights the positive work that we've been doing within Central Zone as well as within the province. So it's nice to really take a day and reflect on that and it really, it's a feel-good day. It's a good day because each day tends to be quite hectic within the unit that you work and within the healthcare system. So it was just nice to see how we're coming together as a province and as an institution and a health authority to improve quality of care for our patients.
Yeah, I agree. I attended a couple of the other quality summits as well, and it's amazing to see the quality work that's happening. That's really improving the quality of care that's being delivered across the province. So, and I agree, it is a feel-good day for sure. So at the summit, you presented your unit storyboard on Safe4F. In general, how has the Safe4F learning journey been going for you and your unit?
So initially, it was quite challenging. We're quite a substantial, large unit. We have 41 beds. I have 65 staff that report to me just for nursing staff with limited resources. So initially, and I am not a quality, my background's not quality. Sure. I don't know, I'm unfamiliar with the quality lingo, and I felt completely lost. I'm not going to lie to you. I felt completely lost. So initially it was very, very challenging in order to gather the resources to make this initiative a success. Carolyn was our coach and from Safe4F. She was fantastic. She did great, but there's only so much she can do hands-on to help us. She did visit the unit, and it was great for her to see like how chaotic and crazy it can be on a unit of this magnitude and size. So initially it was challenging, but as time went on and our tools were put in place, then you could slowly see how the quality initiative was helping improve patient flow and satisfaction on the unit. Yeah.
Great. Yeah. I completely understand when you talk about the quality lingo and not being familiar with that is when it's all foreign. It certainly adds some extra pieces to it to figure it all out. So, yeah. So maybe you could share your storyboard right now, and you could talk a little bit about it and share some of the highlights of your work with us.
So, can you see it okay there?
Yes. Yep.
Great. So initially, we had to review a problem statement or a problem on the unit within cardiology. So what we found that there were multiple, unnecessary discharge delays. We take patients from all over the province, as well as outside the province, because we're the transplant center for Atlantic Canada. So flow is of utmost importance and necessity, of course. So we've reviewed certain causes of the unnecessary discharge delays. Some of them may have been as simple as blood work, a delay waiting for blood work patients that were pending discharge related to blood work. We also looked at transfers to home hospital, complex discharges, those that required like VON and support services at home. So we reviewed, we're like, okay, how can we improve this? Our aim statement at the time was to improve our weekend discharges, because we did find that although our weekend discharges were close to our 25% target, there was still some improvements that could be made there, mainly because our physicians that were on from Monday to Friday would change over the weekend. So they weren't as comfortable discharging them on the weekend. And we wanted to improve our discharges prior to noon. Our discharges prior to noon, we tried to focus on more out of the two, only because we were kind of sitting at about a 6.7%, and our target once again is 33% of our discharge patients being discharged prior to noon.
Sure.
That has been very challenging for us, simply because we have anywhere from 6 to 15 admissions and discharges in one day. So that's in a 12-hour period. So we already have immense flow, and due to the discharge paperwork and the admission paperwork, it's been very challenging to make that 33%. So we were looking at improving it by 5% initially.
Okay.
So we thought of some change ideas. One, to implement physician engagement and multidisciplinary rounds. We do have daily patient rounds with the physician, but our multidisciplinary team are only available at certain times because they cover multiple units. Yeah. So we had to review a time that would work for us to work with PT, OT, social work, continuing care. So during that time, the physicians weren't usually involved in those multidisciplinary rounds. So we started inviting them, word of mouth, communicating with them to say, hey, we would like you to be involved. During those multidisciplinary rounds, we discussed the expected date of discharge, what the barrier is to the discharge, to meeting that discharge date, and then who's responsible for that. It's less likely, we find, that if we review that with the physician being engaged and involved in multidisciplinary rounds, they're less likely to go in the room and say, hey, do you think you need an extra day? Just because the patients maybe, think, oh, they're a little bit insecure and not completely comfortable with going home, or sometimes they, like their stay, in all honesty. So they'll be like, my daughter might be a little bit busy today. Maybe I'll wait until tomorrow. But they're less likely to do that. Physicians are less likely to address it in that way if they're well aware that we have a discharge date set, the patient is aware, and we have that closed loop communication. Sure. So we started including reviewing estimated date discharges with our patients as well.
Okay.
So on this board, you'll actually see our huddle board right there. It's the second picture down on the right.
Okay.
And we created this huddle board based on a template that was provided through SaferF. We took the template that SaferF had initially given to us, but then we printed it off and actually posted it in the patient's room and got their input on what they would like to see on a communication board at their bedside. We posted this with several patients over a period of between 2 and 3 weeks to see what would work and what would not work. On that communication board is the expected date of discharge. So that is reviewed. It's reviewed with the patient daily, with the physician present, so that the patient is aware and the physician is gets to discuss and answer any questions that the patients may have.
Sure. Yeah. Yeah.
So then
What
go ahead.
I was just going to say, like, what a great idea to, ask for patients' input, so you could really have that communication board that really kind of spoke to what patients really wanted to see and know and be available for them.
Yes, well, we thought, well, they're the ones, besides the frontline staff, yes, they're going to use it and fill it out and make sure it's up to date, but we have to make sure it's being utilized by the patient and by the multidisciplinary team. So we did also include PT, OT, and the patient really to be well involved to say, okay, what do you want to see on a communication board that's about you?
Exactly.
And that you need to provide consent for us to use. So they were great. They honestly were, and they gave us the input, and then we went by their input.
Great, yeah.
So we also coordinated with, regarding the blood work, we also coordinated with the manager of the laboratory services.
Okay.
So that we could flag the requisitions for blood work pending or discharges pending blood work results are sent to the laboratory the night before. So I discussed with the manager, just to inquire about, is there a way that we can flag this blood work so it's done early in the morning? They were well on board and said, absolutely, just flag it, put pending discharge at the top of the requisition. And that's been extremely helpful because we usually have that blood work back by 8 o'clock in the morning, which is fantastic. Yeah. Because sometimes we wouldn't see that blood work completed until 10 or 11 o'clock. And then constantly throughout the morning, the physician's like, well, I haven't got the blood work back yet. So this was great. And the lab was wonderful working with us through that. We did include the clinical frailty scale in the admission paperwork. This required immense education for the frontline staff, and our CNE, Carissa Trudeau, work with the CFS network to provide education during our annual Ed Days in the fall. And we've incorporated those in the admission packages for those over the age of 65. And that also gives us, triggers frontline staff who are those at risk for a longer length of stay. And so we can clearly review what their activities of daily living were prior to admission in hospital, so we can get them back to where they were quickly. And as well, which has been, I think, a huge change idea, was our charge nurse with focus on discharge coordination. Back in October, when we initially started the SafeRef, when we really were just kind of getting into the SafeRef initiative, our length of stay is greater than 28 days. We're up to 21.1%, and now we're down to 2.8% by having a charge nurse focus on discharge coordination.
Wow, that's a huge improvement. Must be so happy with that progress.
No, it's been amazing because of our patient population. We've saw such, the complexities of those discharges. We've seen a huge uprise in the last year and a half. So it was amazing that we could identify pretty much right away patients that could have a challenging discharge, and get on top of those complexities right away, whether it be, continuing care or complex care or a complex care unit in a long-term care facility. No, her name is Wendy, and she's been great with helping. And she's been here for the last 30 years, so she's quite well aware of all the resources that need to be put in place.
Yeah, great. Sounds like she's really helped to make some positive impacts.
Yeah, she has. Yeah. So we reviewed the impacts, our EDDs help foster collaboration with patients and families. Like, families are more apt if they see the expected date of discharge on the communication board at the bedside. It it starts communication with them as well, with the primary nurse as well as the family, and the family can start planning. We have less likelihood then for our family the next morning to be like, oh, I didn't know about that expected date of discharge, so now we don't have a drive, or, we see that quite frequently. Oh, I didn't know, and I don't have the house ready, or, I wasn't prepared. I don't have groceries there. I don't have a drive. I need to take the day off. I wasn't well aware. Well, this kind of, for the most part, it does mitigate that issue.
Sure.
Bullet rounds ensures the entire multidisciplinary team is involved in the care plan and discussion, which is wonderful. The physician group, even though they're quite well aware of the medical plan, they weren't always well aware of where they are with where the patient was with like their mobilization or any continuing care needs. And definitely the discharge or the charge nurse focused on discharge planning is eased off the workload and improved coordination of patient discharges. It helps as well with the flow because we're such a large team. We actually have two charge nurses.
Okay.
We have one charge nurse with 20 patients and another charge nurse with 21 patients because I have two rounding teams at one time.
Okay.
They're rounding simultaneously. So they can focus on rounds and communication with frontline staff regarding the plan for the patient, new orders, etc. And she can really, Wendy, the discharge coordinator, can really focus on the discharge needs of the patient and keep flow going.
Yeah. Yeah. Sounds like a real pivotal role for those complex discharges, and with being able to have such a great impact on your patients with long lengths of stay really proves her value with those challenging discharges that are, happen not just in your unit, but happen everywhere. So yeah, that's great information.
Yeah. And as well, even when I go and actually review the data closely, the length of stay for each, like the average length of stay as well back in October 2024 was 8.7 days per patient average, right? Yes. And that's also gone down to 5.7 days in May of 2025. So we've saw a substantial improvement there, which allows, more patients access to the care that they need.
Right. Yeah. Improving that access and flow.
Absolutely.
Yeah. Oh, that's great.
Yeah. So we did do, we had to collect data. So we did collect data. Carolyn wanted us to include data initially on the attendance, physician attendance in bullet round. So I did include those run charts in the storyboard, as well as the progress of our discharges prior to noon. And we just kind of hit under that 5%.
Okay.
As of February, but we were at 6.7% November, and then by February we were up to 11.5%. So we are improving, and it does fluctuate. Really, like I said, it really depends on patient flow because it's so different. It's so difficult to get the patient's discharge preparation, meaning mainly paperwork. So hopefully with OPOR, that'll help with the matter, but it's very difficult to get on top of the paperwork for the next day if you're so focused on all the admissions and discharges for the current day. And it's not one or two admissions and discharges, we're talking about up to 15. So we just, other than getting more pharmacy and physicians involved, and that's not within my wheelhouse, then this is what we can do. But I think we're doing some great work.
Yeah. No, I totally agree. You've really made some great progress with the work that you've done. So thanks so much for sharing that storyboard. Lots of key takeaways, and just, some of those small change ideas that, have really had some positive impacts on, how your unit is functioning. And like you say, with that overall length of stay going from 8, I can't remember the exact number you gave, but 8 point something down to 5 point something, that's allowing more people, access to, that specialty cardiac care that they need on your unit. So that's really great.
Yeah.
All right. If you can stop sharing your screen now if you'd like. There. So with your implementation of SafeRef, is there any advice you would give other units who are still implementing, some of your, I guess, co-units from phase 3 who are still implementing and really thinking about their sustainability?
I would say physician engagement is quite important. They're such a significant part of the team. So including your physician staff, educating them to the best of your ability, and if not, encouraging. I know SafeRef has a physician lead, so engaging them in education with the SafeRef physician lead to help with sustainability. That's quite important, and continuing to encouraging that they attend bullet rounds. Consistent use of your patient communication boards, because that can go to the wayside after a while. Initially, it's all shiny and new. Then after a while, you're like, I find it's easy, not easy, because the units are so hectic and busy, and the acuity is really high. So that seems like it's at the bottom of the priority list. But the physicians, the patients, they really look forward to, to reviewing what's on the communication board. So keeping that up to date and reviewing the expected date of discharges with the patient and the family, I think that's very important. DMS was also implemented the same time as SafeRef with our initiative. Yes. So that was a little confusing first, because I didn't know there was separation between the two.
Okay.
But your performance review meetings are also a great way to continue the communication between you and your staff, and to continue to review areas on your unit that really need attention, and you're able to help communicate that through the performance review meetings, and to look at change ideas in order to improve different aspects on your unit. That really, it helps with staff performance. It helps with staff engagement and satisfaction. So, and it allows staff to let you know that you actually care, and you're there, and you're hearing their concerns. So,
yeah. Well, thanks for sharing those. Those are some really great ideas. Physician engagement is so important, and there are challenges around that, but we know the value of that. So it's important to have our physicians be part of those conversations. And I think your point about the patient communication board, so that the patient, can see that EDD and can have that information readily available for them, really speaks to the value of those boards. And I think, like you say, often they're kind of at the bottom of the list, right? When people are so busy, but it just speaks to the value of those, for the patient and their families. So, some great pieces of information, and the DMS as well. I agree. There was challenges with that, but that helps with that sustainability piece as well. Looking at those key pieces of data and discussing performance in the PRM. So great. In terms of your storyboard, just going back to that for a minute, is there anything that inspired you to present at the Quality Summit? Not everybody likes to present, but anything that's...
I think I got tricked into doing it, actually. I just saw an email from Darius, and I thought, one of the quality leads, and I was like, oh, I did a storyboard. I guess I have to present it. I think it was just, me overlooking the fact that I could
Yeah.
not present.
Yeah.
Anyway, yeah, so it was really accidental, but it was fun.
Yeah. Yeah.
I
Would you recommend other units present theirs? Did you think it was a worthwhile activity for you?
I do actually, because our days get so hectic with operations,
Yeah.
that we often overlook the positive outcomes of these quality initiatives. So this is a way to really focus on, to really review your data that you've collected during the quality of initiative. See how, in our case, flow is improved, discharges before noon are improving, the average length of stay are improving, and just see and just really highlight, oh wow, yeah, we did do all these change ideas, and we did make progress. So it's just nice to, you know, look at those and review those, positive change ideas, and really look and see how far you've come in such a short period of time.
Yeah.
Hmm.
Yeah. Great. Yeah. Yeah. They are a definite positive day. And like you say, it really makes you reflect upon the work that you've actually done. And maybe you don't actually see all those pieces until you really have to look at it to present that information. So it's great. Anything else that you'd like to add or share before we finish up today?
No, not at all. I think, overall, like I mentioned initially, it was overwhelming for someone that doesn't come from a quality background, and we have such limited resources, that initially it just seemed like, it was just a lot of work coming,
Yeah.
coming to the unit level. But I definitely see the improvements that it's made to the unit. So
Hmm.
no, it's good.
Wonderful. Wonderful. Great. Thank you. Well, thanks so much for taking the time to share your SafeRef experience with us, Angela. So today I was chatting with Angela Oldford, Health Services Manager with Nova Scotia Health at the Halifax Infirmary QE2 Health Sciences Centre. This has been episode 10 of the SafeRef Stories podcast. Please like and subscribe to the SafeRef YouTube channel to catch upcoming episodes. Thanks for listening.
Thank you.